All right, good afternoon and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore good syndrome with Dr. Hsi-En Ho. My name is Emma Mertens and I'm the Program Manager of Community Health at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your PI journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Before we begin, I would like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our presenter and be able to hear myself and our presenter speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for our presenter as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn about IDF and explore our resources, please visit our website at www.primary-immune.org. The website offers a wide variety of both online and printable resources for anyone seeking information or support for PI, including our Patient and Family Handbook for Primary Immunodeficiency Diseases. We can also help you find an immunologist or specialist in your area with the clinician window. Visit the IDF Resource Center where you can find all IDF publications, videos, news, and more. You can find information on Good syndrome under our Other Antibody Deficiency Disorders webpage, linked on screen. And we also have videos of past education sessions cataloged in the IDF Resource Center. IDF also has monthly programming and events. We host 2 Lunch and Learns and 2 IDF forums a month. We also have Get Connected groups, peer support, Ask IDF, and our annual PI conference. And now I am so pleased to introduce our presenter for today. Dr. Hsi-En Ho is an assistant professor of clinical immunology at the Icahn School of Medicine at Mount Sanai. Welcome, Dr. Ho.
Thank you, Emma. Thank you so much. Let me just pause my screen for you guys. Okay. I hope everyone can see this. Welcome to the Immune Deficiency Foundation Learn. Our topic today is Good syndrome. My goal today is really to share with you the most current knowledge about Good syndrome and the general advice that we will give. So at Mount Sanai, we're a referral center for immunodeficiencies. So happy to discuss what we do here in general terms. My hope is that I can equip you with the information you need to live a healthy life and to advocate for yourself if something does come up. So this is the outline for today. We will go over what Good syndrome is, what you should watch out for if you have it, and details behind the different treatment options. We'll also make sure to make room at the end for question and answers, and so we can discuss general recommendations. So I thought I'd start out with a little bit background. Good syndrome was first reported by Dr. Robert Good back in 1955, so 60 or more so years ago now. If you or someone you know has Good syndrome, this patient's story may be familiar to you. The very first case was Mr. FH, and he was a 50-year-old guy, and he was well his whole life until suddenly out of nowhere, he developed pneumonia for the first time. And when they got a chest X-ray, they unexpectedly found a large thymoma in his chest. And then so in 1951, they removed the tumor. It was 54 grams. And the good news is that it was a benign growth, so meaning that it was not cancer. Then removed the whole thymoma. But then in the subsequent 4 years, he continued to have pneumonia, in fact, 17 times. And when he finally showed up at the immunologist's office to take a look, and they found that he actually didn't have any antibodies. This is another patient that we saw at Mount Sanai Hospital in New York. This patient is a 51-year-old architect. And his presentation was he had a long history of recurrent sinus infections, but they were never really severe, and they had never really required IV antibiotics or need to be hospitalized. Then one day he actually felt very poorly and fainted. He went to his primary care doctor and found that his chest sound actually sounds a little bit different from normal. So then they got a chest X-ray as well. And this is actually his imaging on the right here. The red outline is usually the only area of the chest X-ray that is supposed to be white, and that's supposed to be our heart. And as you can see around there, I don't know if you can see my mouse cursor, the bigger white area that's not supposed to be there, that was his thymoma. So this patient also had the thymoma removed surgically, but then afterwards he continued to have sinus infection, so he went to an allergist. And that's when they did the antibody tests, and these are the IgG, IgA, IgM are the antibodies, and across the board they're very, very low and near absent. And that's when the patient was referred to us for further evaluation and treatments. So what is Good syndrome? There's four main things that I like to focus on today. Overall, it's very rare, and it is the main characterization is the presence of thymoma either currently or previously. And along with that, what our patients will have is significant antibody deficiency, and this was presumed to not be there before the thymoma. Additionally, the syndrome is also associated with additional immune problems. So you can have immune problem with T cells, which we'll go over in a little bit, and some patient can have autoimmune issues, which I'll also discuss in detail in a moment. So I start off from the background, what is a thymus and what is a thymoma? Thymus is a gland actually at the top of our chest, right below our breastbones. It's in the graph here, it's this green butterfly thing, right at the front of the chest. It's usually large in infants, that's when it's the most active. And usually when you become an adult, they become very, very small or near absent. So usually we're not supposed to see them on chest imaging. The gland has been known for a long time. It's derived from a Greek word called thymus. People have thought that it's the seat of the soul, and it has been thought to be kind of a mysterious gland because people don't know exactly what it does. And to this day, there's still quite a lot we don't know about how exactly thymus work, which I will talk about as well. Now, what we do know about thymus is that, it's kind of like a training ground. I think of it as a school for a specialized immune cell called T cells. So this is actually where young T cells go. And then at the thymus school, they will actually learn about what's good and what's bad. And then they're basically trained to really attack the microbes, so things like bacteria, viruses, and fungi. At the same time, the troublemakers, the bad T cells, the school also actually weed them out. So the T cell that can attack our own body, they're also removed so they don't cause a problem down the line. And then most of this happened during the childhood. That's when we get most of our new T cells. As an adult, most of the time it's stabilized and we're not producing as many new T cells anymore. Now, so what is a thymoma? Thymoma just means it's a tumor of the thymus gland. And overall, it's very, very rare. So people don't really think about it. It typically occurs in the 4th to 6th decades of life. So, from 30-something-year-old to 50-something-year-old, that's usually when it is found. And there's no known risk factor for it. So it's not like, has nothing to do with, any exposure you may have throughout life, so it's not really related to smoking or other known risk factors. It tends to be very slow growing. And the good news is that most of the time it's benign, meaning that it's not cancerous and does not spread. But in rare cases, sometimes it can be malignant, which is why it's always important to remove the thymoma if we do find it. So what are the symptoms of thymoma? How can they present? A lot of times, this is actually an incidental finding, like the 2 patients I talked about, the very first case and in the case here at Mount Sanai. A lot of times it's, people getting chest x-rays for some other reasons and found incidentally. Some people, they can present as chest pain, chronic cough that just won't go away, or a shortness of breath that just won't go away. And this is because the tumor actually sits right near the heart and the lung. So in this picture, it's the circle red part right here. And it's literally directly above this patient's heart and right in front of the patient's lung. So when the mass is pressing on this organ, that's when it can cause the cough, shortness of breath, or chest pain. There are a couple other strange things that thymoma can present with. 2 of the more common ones. One is called myasthenia gravis, and this is an autoimmune process where people can develop muscle weakness. Another one is something called red cell aplasia. It's also an autoimmune process. Basically, our body red cells are being, our body is not making as many new red cells anymore, and that causes anemia. And very rarely, in most reports, around 5 to 6%, there's one report that showed that up to 11% of patients with thymoma, they can develop an immune deficiency. And that's when it's called the good syndrome. Now, stepping back a moment, the way I think about our immune system is I kind of think of it as a sports team. So I'm not a sporty person at all, but this analogy works in my mind. Basically, our immune system is composed of different players, and they all do different things. They all specialize different things. You have quarterbacks, you have frontline person, some people who are very good at defense, some people are very good at attacking. And in good syndrome, 2 of these players are affected. The first one, the most prominent one, are the B cells, which are the cells that produce antibodies. So what are antibodies? I kind of think of our antibodies as our body's missile defense system. So our body makes these missed cells, and each one is against a specific bacteria, virus, or fungi. So normally, if we encounter this in real life, our body fires off its missiles and get rid of the infections for us. So it can get better quickly, or maybe we won't even get sick at all. And the cells that produce these missed cells are called the B cells. In good syndrome, these B cells are either very low, or more commonly, they're completely absent. And the reason for this is not exactly known yet. Another part of good syndrome where your immune system is affected is a T cells. And this part, not as many people appreciate, and something I think it's important for us to know. So what are T cells? I think of T cells really as our immune system's quarterback. The reason is because they are really the ones that coordinate our immune response. So they kind of tell, this person should really go after this bug. They help train other immune cells so they can be even better at attacking this bug. And if you recall, these are exactly the cells that are being trained at thymus. So it makes sense that when you have a thymoma, this group of cells is affected. And these cells are especially important for defense against some rare viruses as well as fungi. So which is why, if you do have this syndrome and if you do have an infection, we do have to make sure we think a little more broadly, sometimes to a little bit more rare things. And that's because in good syndrome, the T cells may not work as well as other people's. Now, so if you have good syndrome or thymoma, what should you watch out for? What should you anticipate? The number one thing is really infections. So this is one of the biggest study to date. It's from the United Kingdom. They have a database of the whole nation. So they pull all the data together on 78 patients and see what the patient with good syndromes were reporting. And the number one thing they found was bronchiectasis. So I think of bronchiectasis as lung damage from recurrent pneumonia. Kind of like, imagine if you got a scrape or a cut on your skin. If it just happened once, it will heal by itself and your skin will look normal. But if you keep getting injured in the same area, you can imagine you can get scar tissue start to form and you have a permanent scar in the area. Or if the cut is too deep, then you have a permanent scar tissue. Same thing happens in the lung when you get a pneumonia. So if you keep on getting it, as you can imagine, our lung is where we breathe. And if you have a scar tissue there, that's when it can affect your breathing down the line. And so that's bronchiectasis. It's one of the main things we should really focus on in preventing if you have good syndrome. Another common thing that people report in about 10% of the patient, it's sinus infections. And this is because there's a specialized antibody called IgA. They actually coat our mucosal surfaces around the sinus and the nose and help us fight infections there. So when you don't have these mucosal antibodies, you are at risk of getting recurrent sinus infections. And sometimes this can be chronic and ongoing. And these are some of the bugs that can cause problem in good syndrome. I compiled this from the UK report, as well as our own patient cohort from Mount Sanai. And the goal is not necessarily to know all these bacteria and viruses and fungi. Appreciate that different things can cause issues. So if you do get sick, make sure you look a little bit broadly and making sure that they're not just thinking about the common bugs. They may want to think about some rare bacteria, fungi, viruses as well. And one of our patients, actually, he was traveling abroad and he drank some water sources and he actually got giardia, which is kind of like a parasite infection. So also something to keep in mind is if you go travel or develop a country, make sure your water source is clean. Now, the last part about good syndrome and something that you should watch out for is autoimmune conditions. And it's something that's, has been known to associate with good syndrome. This is the same report from the United Kingdom. So autoimmune problem is found in about 26, so about a quarter of the patients. The most common issue is low red blood cells, and that's about 10%. Some people have thyroid disease, so their thyroid hormone could be low. Other people can have arthritis, so their joint can be inflamed. On a more rare scenario, people can have myasthenia gravis, which is a muscle weakness problem. Some people can have lupus. Other people can have Sjogren's disease, where you can have really dry mouth and dry eyes. And this is actually all related to autoimmune. And it's something that's to keep an eye out for if you do develop unusual symptoms that are not necessarily infection, but something still off. It's good to talk to your immunology to see if something that's could be related to good syndrome. So now, if you have good syndrome, what are the treatment options? What should we do? So, this is what we do at Mount Sanai, and I think, it's the same across the board for the most part. The number one thing is we need to remove the thymoma. And the reason again is that even though most of the time it's benign, sometimes it can be cancerous. So we do have to remove it to make sure that it doesn't become a cancerous process. I get this question a lot. A patient will ask me, if I remove the thymoma, this tumor, will my immune system recover? And unfortunately, that does not seem to be the case. For a reason that we don't know yet, what the thymoma does to our immune system seems to be permanent. So we have patients that we've been following for the past 30 years, and their antibodies are still very low after all this time. The second thing that we really focus on if at good syndrome is we know that your antibody is low. So what we really need to do is replace the antibodies. And I kind of think of it as almost like a gas tank. So imagine a gas tank holding antibodies. So in people with good syndrome, the gas tank is empty. So what we can do is we can actually pull antibodies from hundreds of donors into this vial, and we can give that to you either once a month or once a week to fill the gas tank. And what that will actually do is you'll make it essentially back to normal, and you'll get the protection of antibody against a wide variety of bacteria and viruses. So it's actually really neat. I always get questions about, what kind of treatment is the best? And you probably know this, there's different forms and different brands. So there's the IV version, we call it IVIG, and there's a subcutaneous, meaning just underneath the skin, and that's sub-QIG. I tell patients there's really no right or wrong. You should really do what's right for you, what makes sense for your lifestyle, and what makes your life easier. So, some people don't like to have, medical equipment at home. They prefer just to go to an infusion center once a month and not to think about it, just have a nurse do it. If that's you, that's a perfect option. I think IVIG is great for that. For sub-QIG, some people, some of my patients are, they're New Yorkers, they fly across the world all the time. They want to have flexibility and travel whenever they want. They don't want to have to think ahead and make appointments. So for them, sub-QIG might make sense where they can just do it at home choice. In terms of efficacy, both works really great. I'm happy to answer more questions about IVIG as well during our Q&A session. And if we make sure that your antibodies are properly corrected, that will take care of the most of the problem. It will prevent most of the infection. In rare cases, if you do catch an infections, this is when we want to make sure we are proactive in treating it. So we can, something I always tell our patients that, let's get a culture let's find out what we're dealing with. Is it bacteria or is it something else? And depends on what we find, then we can choose the right antibiotics or the right antiviral treatment for you. Now, the last part is not standard, but something that we do here at Mount Sanai. So if you have pre-existing lung disease, so if you have pneumonia multiple times already, you have some lung damage or bronchiectasis, we talk to our patients about considering an antibiotic prophylaxis. This is just a way of saying that, hey, your lung already takes some damages already, and we want to make sure that, we don't run into any further down the line. So we give you another line of defense on top of the IVIG to really help minimize any problem bugs from getting into your lung. I don't think not everyone does this, but it's something that it's more common now. So if you have lung issue, that's definitely something to talk about to see, some people will use azithromycin, which is Z-Pak, and then they can use that prophylactically to prevent minor infections from happening. Last part is, if you are, the cordial patient that end up having some autoimmune problem, this is when I tell my patient that, we'll work with a specialist to treat the autoimmune condition. So if you end up developing a lupus-like symptoms or Sjogren-like symptoms or joint problem, a lot of times we'll loop in a rheumatologist. And the good news is that having good syndrome really doesn't change how they will manage this separate autoimmune issues. You will still get the standard treatment for each of the condition, depends on what it is. And I think the key here is really that, you should pick a doctor that has good communication with your immunologist so they can work together. If you end up having red blood cell problem, anemia, then we'll loop in a hematologist to help manage that at the same time. But all these conditions, there are good treatments for. And then couple of treatment tips I tell my patient. These are the three main things I think that take home points to think about, and then really use to advocate for yourself. I think the most important thing is to know that Good syndrome is a very rare disease. If you talk to your family physician or even other specialists, they may not have ever heard of it. So, it's really important to check in with your immunologists who are the specialists in this rare disease and have more knowledge in the area. And when you meet up with them, tell them about any infections you have in the interim, so they can kind of assess whether they need to change any of your IVIG dosing. IVIG is actually weight-based treatment. So if your weight changes by quite a bit, like if it changed by more than 10 pounds in the past year or so, let your doctor know because they may need to up your dose a little bit. If you have any new symptoms or new medications, it's always important to let your immunologist know so they can see if there's something else they need to consider, or they will work with you to make sure that, some other immune medication not suppressing your immune system further too much. We usually check our patient's antibody IgG level about once or twice a year. And this is really just to make sure that, our patients are on the correct level of treatment, and then that they're fully protected, especially, in a setting of a pandemic. So I think it's good to check that once or twice a year. And it's also good to stay ahead. Some of you may have experienced, IVIG, it's an expensive treatment. So sometimes people run into problem with insurance in getting prior authorization. So it's also a good idea to stay ahead of the issue. So make sure that, we get a routine blood test done, the routine physical done. So if the insurance has any issues with prior authorizations, everything is ready to go, and we can make sure there's no lapse in your infusions. The second thing, major take-home point, I think, is just advocate for yourself if you do have infections. I think it's really important if you do get sick to get culture so we know what we're dealing with. I think one of the main take-home point is that a wide variety of bugs can be troublemakers if you have good syndromes. So we do recommend treating broadly, especially if you get sick and a doctor gives you antibiotics, you're not getting better. Do advocate yourself. Just tell them that, hey, you have good syndrome. Should we consider a little bit broadly? Should we test for other viruses, maybe a little bit more unusual bacteria or fungi? It's good here to, especially if not getting better, it's always good to think a little bit broader so we're not missing anything else. And lung health, I think, is very important. If you start noticing shortness of breath, if you're exercising, you're out of breath a lot more easily, let your doctor know, because it might be good to do a lung function test or get some additional imaging done so we can make sure that your lungs still okay. So some of my patients do have chronic sinus issue. And so another good tip is it may not be a bad idea to loop in a ENT, a ear, nose, and throat doctors to help co-manage. Not necessarily to have surgery. Most of the time, surgery is not going to fix your sinus issues. And what you should also know is that IVIG, because it's going to bloodstream, it doesn't go into your sinuses. IVIG doesn't usually help with the sinus issues. So this is when where an ENT doctor can be helpful because they can do compound topical rinses. So a number of my patients are on topical antibiotic rinses daily. And if the sinusitis is a big problem for them, and this is actually a very good targeted way of trying to prevent the sinus infections from coming back. I think the last tip is also very important. If you have a new symptoms, don't let both your primary care doctor and immunologist know. If you have a new health problem, it may just be related to general health, but sometimes it could also be related to the good syndrome, because good syndrome people can have some autoimmune problem. So let both of your doctor know so they can think about and take a look and see if it's something that could be tied in to good syndrome, or could it be something completely unrelated. So COVID, I think that's something I know we're 2.5 years into this, but I think it's on a lot of our minds. So this is what we tell patients with good syndromes and with antibody deficiencies, just general advice. Talk to your doctor about vaccination and masks. These are helpful. I think masks, especially if you're in a crowded area, if you're in a very crowded, packed airplane during the holidays, it can provide some level of protection. We've been using antiviral therapies if you do get sick. Paxlovid is the main one right now that's approved by FDA under their emergency authorization program. What you should know is that Paxlovid works the best if it's given early during the course, so within the first 5 days. So what I tell my own patient is, if you do get sick, you think it might be COVID, just do a rapid test rather than later, because it's within the first 5 days. Just reach out to your doctor or immunologist. You can get Paxlovid, and it's actually very good at preventing progression to severe disease. The only thing to think about is the Paxlovid does have some drug-to-drug interactions, so make sure you ask your doctor and pharmacist to check to make sure there's no interaction. If this interaction doesn't mean that you cannot take Paxlovid. Most of the time, they may just adjust the doses of your other medication a little bit so you can safely take it for that 5 days of the Paxlovid. I also get a lot of questions. You probably have heard there's sometimes there's COVID monoclonal antibodies that people have been given even as a prophylaxis or get sick. And this is one area that's constantly changing. So my best advice is talk to your immunologist to get the most up-to-date information. The reason is because the virus does change over time. So a monoclonal antibody that works 5-6 months ago may not be working against the new variant in your local area. So definitely talk to your local doctor and hospital to see, what's the prominent variant right now, and whether if monoclonal antibody is actually working now, or if it's not working at all, then it may not be worth it. Well, then we'll mainly rely on the antiviral, the Paxlovid treatment. Okay, so this syndrome summary. So overall, it's really rare, and we think it's a acquired immune deficiency. It's really the immune problem happens after the thymoma has developed. And it's really characterized by previous or current thymoma. And our patients also have very, very low B cells and antibodies. Removal of thymoma actually doesn't correct this immune problem. And not just antibodies, your T cells can also be affected. And additionally, in about a quarter of our patients, they can get autoimmune disease on top of infections. And the reason for this is not still fully understood, and definitely an area that a lot of us immunologists are still working hard to try to figure out what exactly is making the antibodies going away and what is exactly causing the autoimmune issues. I think the good news is that for any of the main issue, the four issue, the thymoma, the antibody problem, the T cell and autoimmune system problems, they're all very treatable. So thymoma, we will remove it, and most of the time it will be benign. For antibodies and B cells, we can give you antibody replacement IVIG, and that is really good at treating infections. In rare cases, if you still have infections, we typically have very good antibiotics and antiviral to provide. And for autoimmune disease, having good syndrome doesn't necessarily change the treatment for that condition. So we'll often collaborate with a rheumatologist or hematologist to treat the autoimmune issue. So I hope this information has been helpful to my own patients. But I would also like to open the floor up to see if anyone has any questions that I can help answer.
Wonderful. Thank you so much, Dr. Ho. That was a great explanation of good syndrome. All right, really quick, I'm just going to reshare my slides. All right, so before we get into Q&A, I just want to remind everyone that if they have questions, that they can enter them in the little Q&A box on the control panel on their Zoom screen. All right, so our first question. All right, so this individual is asking for a friend. Let's see. They are asking, is there any explanation for why the number of T helper cells varies so much? And then they said in parentheses, to explain, my helper T cell or T helper cells have been very low for almost a year, but at the moment they are relatively high despite various infections that I am experiencing.
That's a great question. So we do know that in some patients, the T cells are affected, especially the CD4 T cells. And as you can see, not all good syndrome patients present exactly the same way. There's definitely variabilities there. So, not everyone will have autoimmune problem. The most universal thing about good syndrome is really the B cells and the antibody, and that's almost for everyone. If you have good syndrome, that'll be universally low. For CD4 T cells, the number can actually be a little bit over the place. So this is really patient by patient specific. And your CD4 T cell, I'm actually not surprised if it changes over time. Sometimes certain infections, certain viral infections like COVID, they will actually suppress your CD4 T cells further temporarily. While other times when you get other type of infections, your CD4 T cells are working extra hard, and that's when your CD4 T cell will be go back to higher level. I think the way I think about CD4 T cells is that there's a minimal threshold. So the typical number we think about is CD4, not the percentage, but the absolute number above 200. Usually that's the minimal threshold that our immune system needs to be able to fight against infections. So if you notice that your CD4 is below 200, that's definitely when you should reach out to your immunologist. That's maybe they may want to intervene further.
Wonderful, thank you. All right, next question. So you mentioned various sort of manifestations that someone with Good syndrome might experience, including arthritis and lung problems. So in addition to their immunologist, what other clinicians might someone with Good syndrome expect to have as part of their care team?
That's a great question. So, I think it's a double-edged sword, because sometimes I feel like we see too many doctors sometimes. And I think usually for us, I think immunologist is a good gatekeeper. So I think a baseline, make sure you have a good primary care doctor and a good immunologist. And the rest really depends on what problem are coming up. So you're probably not excited to have to follow 5 to 6 doctors all at the same time for one problem. So I would say that, if you start developing joint problem, that's when we would loop in a rheumatologist. If you start to have thyroid issues, we'll loop in an endocrinologist. If you have anemia, then we'll loop in a hematologist. So it's really problem as they arise. But that's something that, once a year, your immunologist and primary care doctor can run this routine test. They can test your blood count, they can test your thyroid hormone function, which should be a part of your routine test anyways. And if you start developing cough or shortness of breath, this is when they'll get a chest X-ray, and they may see if there's other lung problem where we need to have a lung specialist loop in or not. So I would say really as needed, and maybe save yourself some problem. It's better to have consolidated case, and if you need it, we can always expand your care team.
Wonderful, thank you. All right, this individual said, great talk, which I agree. And then they asked, do you have any additional research or publications that you can recommend in relation to Good syndrome?
Oh, that's a great one. I don't know if there's a mechanism for this. I'm happy to send out a few articles that I do like. I can, maybe I can send them to Emma. I don't know if there's a way that we can post it on the website. Just because I know that I think Dr. Google can be hard sometimes. It's hard to find, what's a good paper and what's a good source and what's not. I can try to compile a few articles that I do like, and then some can be very, very intense academic, and some will be more general for you to read.
Wonderful, thank you. And yes, if you email those to me, Dr. Ho, we can send them out to folks who registered for the webinar. So that would be great.
Awesome.
All right, next question. This individual says, thank you, Dr. Ho. Do you have a recommendation for a low OGA subcutaneous product?
Oh, that's a good question. I don't know the specific of the, so we don't usually need to worry about the IgA content unless your body is making antibodies against IgA. So this is a little bit more technical. So our current knowledge is based on a Canadian blood bank study, because they have a nationalized system for their blood bank system. So it's true that some people can make antibodies against IgA, and in those patients, the infusion sometimes can be of problem. What we do know is that subcutaneous IG, usually we don't see those problems anymore. So usually sub-Q IG, we don't consider too much about the IgA product. For in general, I want to get the most up-to-date brand for you. It's actually Immune Deficiency Foundation actually has, if you type in Immune Deficiency Foundation and type in IVIG, there's actually a very good handout. I have all the product listed out, and I highly recommend for you to check out, because I don't know if I'm allowed to go in. I'm allowed to recommend specific brand company over another here. That's my one worry. But if you search that booklet, they'll list all the product out there, and they actually have a row that says IgA content, and you can compare and contrast.
Yes, I'm going to look for that link on the website as we're doing Q&A, and I will put that in the chat. So thank you so much.
Yeah. But usually I would say that if you have a problem with IV and they think it's related to IgA, definitely check whether you have anti-IgA antibody. And usually the subcutaneous form, it's better tolerated, or you can find a low IgA IVIG product.
Thank you, Dr. Ho. All right, next question. This individual asks, is there any prophylactic medications that you recommend that would cover all the bases, like a broad range of infections?
So there's not one golden bullet for this. I think the best way, the most broadly covered, is the IVIG, and that's what we rely on the most. In terms of antibiotics, the best study that has come from so far is a study from Italy, and this happened just right before the pandemic. So the one they used in that study is azithromycin, which is Z-Pak. So they used that half a dose 3 times a week in a study in patients with antibody deficiencies. And it's a double-blinded placebo-controlled trial, so it was the gold standard. It's very well done. And what they found is that if you have a lot of recurrent lung infections or respiratory infection issues, that is something that can be helpful. So that's something that you could consider to talk to your doctor about. But what you should know is that azithromycin covers mostly bacteria and certain bacteria, so it will not cover against viruses or fungi. And we don't have a magical solution that will cover everything. So I would say definitely we still rely on IVIG as really the backbone of the treatment.
Thank you, Dr. Ho. All right, the next question. This individual asks, what is the estimated mortality rate for people with Good syndrome who get COVID? Dr. Sullivan had previously reported, I'm guessing this individual is referring to in one of our last COVID forums, that the bad news of it being around 50%, but that was before the Omicron variant, especially if one is on immunosuppressants.
Yeah, and this is something that's constantly changing. There's the COVID is constantly evolving, and what we do know now is that Omicron seems to cause less severe disease compared to Delta and the previous variants, and we don't have really the full set of Omicron data for the primary immunodeficiency population yet. There's a couple of factors here now, because it could be a virus issue, but at the same time, we've been using PAX a little bit more, and I think that's also helpful. So that can help to prevent severe disease. For earlier this year, there was a couple monoclonal antibody that works pretty well against Omicron. So those have been useful in reducing, I think, severe disease as well. Though with some of the newer variant, the data is being updated right now. So I think overall, some of these data are changing, so we're still waiting for the newest data right now. In our own center, people are in general doing much better. So I highly encourage our patients to just stay on top of it. If you do think you might have COVID, you have exposure, do a quick rapid test, and we can get you to have Paxlovid early on. It's a good way to really prevent severe disease.
Wonderful, thank you. All right, next question. This individual asks, what are your thoughts about oral IgG? For example, cow or goat colostrum?
That's a good question. So it has actually been tried before. People have made it. The results wasn't that impressive, which is why it's not in use anymore. And the IgG is the most active, in our bloodstream. That's when it can prevent pneumonia and prevent severe infections. I think most of the time, if you drink it, it pretty much just pass right through, unfortunately. So this is why we don't really use it anymore. I know that I think there's some group are thinking about, I think there's some biotech startup that's thinking about, can you spray immunoglobulin into your sinus or nose? I think that's something that people are thinking about on a theoretical sense, but that's not something that's available either. That's a great question.
All right, thank you. And then this last contribution is actually, it's a comment, not a question, but this individual was letting us know that there is a Good Syndrome support group on Facebook with 117 members. So I'll go ahead and share this is not an IDF group, I just want to make that clear, but I'll go ahead and I will share that link in the chat so that if anyone wants to check out the Good Syndrome Facebook group, they can do that. All right, well, thank you so much, everyone. That's going to wrap up our Q&A. Thank you for all of your wonderful questions and for your engagement. And thank you, Dr. Ho, for answering all these questions. Thank you so much again, Dr. Ho, for your wonderful presentation. And before we close out, we just want to remind you to take advantage of all the wonderful resources that IDF has to offer. To find our resources on Good Syndrome, you can visit, again, our main page is primaryimmune.org and search for Good Syndrome using the toolbar, or you can visit the IDF Resource Center, where you'll find videos of every IDF education program, countless resources, and opportunities for connection within the PI community. To our audience, if you have additional questions, you can ask IDF. Go online and submit your questions to Ask IDF at www.primaryimmune.org/ask-IDF. And I just want to say this is a great place if you have specific personal questions to ask about your PI that maybe you didn't want to ask during the Q&A. This is a great way to get your very particular questions answered, is by going through Ask IDF. So we definitely encourage you to check that out. And we want to close by saying that all IDF programming is truly guided by the needs of our PI community, and we want to hear your feedback. So with that, I'm going to launch a quick poll right now, asking the audience to let us know what their level of comfort is with indoor and in-person events. So gonna go ahead. Oh, there's no poll in here. Well, disregard, we're gonna skip over that poll, but please know we are getting that data from our community right now. And you'll likely be asked in another, if you attend a forum or another IDF event, you'll likely be asked what your comfort is with indoor and in-person events. And finally, I just want to share a preview of our upcoming programs in the next couple of weeks. We have our Walk for PI virtual celebration on December 14th at 7 p.m. Eastern Time. And then the following day, we actually have our final IDF Forum of the year, which will cover COVID, flu, and RSV. So we hope to see you at the next IDF event. Thank you so much, everyone, for all of your participation. Oh, thank you. I'm reading your comments in the Q&A right now. Everyone's very appreciative of your presentation, Dr. Ho. So thank you so much for putting this together for our PI community. Thank you, everyone, for your engagement and participation. We really appreciate it. And that wraps up our Lunch and Learn on Good Syndrome. Thank you so much. And I hope everyone has a great rest of their day. And thank you again, Dr. Ho. Take care.
Thank you. Take
Thank
care,
you.
everyone.
Bye-bye.